Hello, everyone, and thank you very much for having me here. Um, I'm Rokas Navickas. On behalf of our team, I would like to briefly recap the improvement planning process in Lithuania. So next slide, please. As part of the project Rokas Exchange, our team was driven by potential contribution to what's actual implementation and therefore actual gains for the community when transferring knowledge to practice. With an objective to improve multimorbidity care, we prioritized public health services within primary care, where most of interactions usually happen. When using the tool, as part of Rokas Exchange, we aim to align the focus of improvement planning together with activities identified during the knowledge transfer process, which in our case was change package. Basically aiming for better disease prevention, healthy lifestyle promotion, raising population's health literacy, and implementing integrated health services. Obviously, implementation while scaling up was, again, our priority. Next slide, please. The improvement planning activities focused on implementation of innovative, accessible multimorbidity health service models at a national level. The most important improvement planning activities included 2 workshops meant to develop a high-level logic model. During the discussion about different components of the improvement program, a draft version of the model was developed. That model later was reviewed and redefined several times as needed through emails with work package leaders and obviously stakeholder input. During the second workshop with a stakeholder group, we tried to finalize a more user-friendly logic model, which contained planned activities of capacity building, translation, administration, patient education, and relationship building. Now, if I may go into a little bit more detail into each of them. So capacity building in our case included knowledge exchange between primary care centers, like pilot sites, and also integrated care training for providers on structure, implementation, and patient inclusion and self-management. The translation part included model adaptation to local context. The administration included definition of a case manager role and scope of practice, as well as development of individual healthcare plan templates. Also assessment of multimorbid patient social conditions and involvement of social workers in care of multimorbid patients, obviously when needed. Patient education included training of patients on self-management, as well as collecting patient self-management resources. And the last, the relationship building, included intersectoral collaboration between providers and health bureaus, as well as voluntary stakeholder meetings for dissemination of initiative. Next slide, please. To sum up a reflection on improvement process, we have highlighted mainly 4 types of challenges. As the first and probably most crucial one was a challenge to choose motivated and capable stakeholders. It was also important to define and agree on easily measurable, minimal amount, and easily measured outcome indicators. Third one was well-defined target group of patients. In fact, as a highlight in the feedback form from the stakeholders, a further more specific definition of the target group could follow, prioritizing the ones benefiting the most as defined by the stakeholders, meaning that most difficult patients consume more time and more healthcare costs, so it might be beneficial to concentrate even more on reaching the biggest spenders, where the actual biggest difference for the stakeholders will be as well. And the last one is, of course, the activities and input needed to reach the outcomes previously agreed on. We strive to define the activities that would not bring significant burden to the stakeholders when implementing in practice, such as avoid duplications, etc. Therefore, repeatedly, we reviewed and questioned the processes. Were they beneficial? Were they needed? Were they not duplicating one another? In order to optimize the additional resources consumed for the process for each of the stakeholder. Next slide, please. In our case, the logic model brought a structured and clear plan how to support the stakeholders when improving the regional integrated care work. At the times when so much is known, it is it is so easy to have access to all the information, it becomes a matter of good implementation when aiming for a change. And that is exactly where the tool supported us, or served our team as a tool to scale our availability, our limited availability, in supporting the others. As stated previously, the project was mainly about expected outcomes and reaching them. Expected benefits here were to increase healthy life expectancy, increase clinical outcomes, service availability, number of remote health services, reduce administrative burden through increasing professional competence, better collaboration between team members, and better working conditions, as well as reduced number of hospitalizations, including outpatient visits, home visits, hospital readmissions, as well as in general optimize usage of resources. Next slide, please. And at this last slide, I would like to share with you the great potential and the activities that was initiated by Shiroko Exchange, but more importantly, goes beyond the scope of it. For further improvements, considering the integrated multimorbidity patient care, the Ministry of Health in Lithuania, together with a project team support, launched 15 pilot projects across the whole country, covering 46 primary healthcare centers with an aim to improve integrated care. Even though the project came to an end, during the project, we managed to set the ground for an extensive support, ensuring the teams were trained and made independent in continuing with improvement process after the support runs out. This is a rather good example how the needed know-how was identified, later applied, teams were supported, and further self-sustained improvement was implemented as part of the project. But as I said, going well beyond the existence of it. Thank you very much.